Thank you very much. I would like to thank Dr. Khanna for his kind invitation. And since the ISS sponsors this station, we do it with much pleasure, and we will be present next year. You asked me to speak on patient selection and pre-case planning, and the previous speaker just opened the way. I'm going to tell you the way of thinking about this selection in Europe. As you know, there is a big importance of screening because of the risk of rupture for abdominal aortic aneurysm. These are silent and instant killer. It's why we have these two options, to open surgery or EVAR. Because the risk of rupture per year is tremendously high in a big aneurysm, 50% into the year for big aneurysm. Open surgical repair is a reference, but there is an operative time, there is an effect of clamping, sometimes transfusion. You have to put your patient in ICU, and the hospital stay is longer. Joan Parodi, a very nice person in Argentina, did invent this concept of graft implantation, endovascular graft implantation in aneurysm, and we must thank him. He was a pioneer, probably one of the best pioneers that you know about. So we must also give a word about Nikolai Vodolos, who in 1995 in Ukraine, in the former Russia, did a lot of work on the same topic. The initial Parodi system was just an implantation of a Dacron tube between two palmar stents in an ortho-aortic way. Now we have very good graft. Some are lower in diameter of introduction, and they are all available with a short incision. The system is a suprarenal fixation with hooks, which permit to fix and a better fixation. The main body with a modular contralateral branch. You all know this basic concept. But you need a good patient selection with approved graft in a center of excellence, in a good operating room with a sophisticated C-arm or cath lab in a sterile environment with a surgical security. You need also a construct injector. This is a necessity. And you need a vascular team, not only a vascular surgeon, but an angiologist for the diagnosis, a good intervention cardiologist, and all the other team available 7 days, 48 hours a year. Because sometimes you have to do open surgery for rupture aneurysm, and you know the chances are low to keep the patient alive. You have sometimes some acute complication during EVAR, and sometimes you have failure to cross, as the previous speaker showed. Sometimes it's impossible to get through. And also, you have to deal with the contraindication of the endovascular technique. You need an experienced vascular surgeon in your team. Look to this diagram. You will understand that bigger is the aneurysm, less the endovascular technique is feasible. I think it's normal, because the anatomy of big aneurysm become tortuous and difficult to deal with. As you know, we all accept the concept of EVAR after the EVAR-1 trials, and as you know, the mortality is much lower in the EVAR technique compared to the open surgery. That's a reality from the randomized trials. Anyway, you have to make a AAA risk evaluation. In fact, you have to decide the indication for intervention. This is 55 millimeter in diameter or 1 centimeter increase within the last 6 months, a saciform aspect, or a pain, aneurysm with pain, which is an emergency. You have also to deal with the anatomy, saccular against fusiform, because the treatment could be different. This is the ideal case for EVA, but you have to deal first concerning the anatomical selection. You have to deal with the neck, the length. Don't go if the neck is inferior to 15 millimeter. Please don't go. Diameter. If you have a big diameter superior to 28, be careful. You won't have any graft available. The angulation. Respect the rule of 45 degrees. Don't push too much your indication. The shape, conical or inverse conical, this will be a way to migration. And if you have thrombus, be careful. Sometimes some people does implant a graft with thrombus in, but be careful. You have also to deal with the iliac arteries. Aneurysmal extension or not. Look to the hypogastric emergence, to the diameter of the landing artery. Is there any calcification or stenosis on your way? And do you have any tortuosities? Anyway, you have to see the global conformation of your lesion. You have to look to the inferior mesenteric artery. Is it open or closed? And anyway, you have to deal with the external maximum diameter in systolic. What's the protection problem for the access? Stenosis, occlusion, diffuse disease, tortuosity, small diameter. You will have to deal with it, sometimes dilate, stent, or stent graft first. Pave and crack. The aneurysmal extension to the iliac artery exists in 25% of the aneurysm. And sometimes look what is inside. So careful, be careful of atheroembolism during your procedures. Common iliac arteries, this makes the procedure more difficult, and you can have a reintervention rate when you deal with bigger artery, not aneurysmatic, but big. And sometimes you deal with complex aneurysms, like this one, aortic aneurysm, iliac stenosis, iliac aneurysm, which will be treated by auto-uni-iliac stent graft and femoral bypass made by a surgeon. Look to this one. There is several lesions, a big aneurysm and a common iliac aneurysm involving the hypogastric. And you will have not embolic type 2 because the inferior artery was not visible in that case. Computer tomographic angiography is a reference, but you have now dedicated planning software. Your sizing is fundamental. You can do it yourself, you can ask the rep to do it for you, and you can do it collegially. Be careful because the sizing must take into account the adaptation of the graft to the anatomy. and there is a length variability with a non-deploy compared to a deploy aorta. So, 1 minute. Tortuous ear migration. This case was not well sized. The fixation was bad and also undersized. And this is the result with an too angulated neck. So be careful to your indication. Here, no proximal neck for an iliac aneurysm. This will be orthobiliac graft. If you deal with a common iliac artery, you have to coil the hypogastric artery and stent graft the iliac. Fenestrated stent graft, that's important for the pararenal or juxtarenal aneurysm. And now you have an evolution in the technology, but the sizing is very important. You have to work on it first with the company. And this is complicated, but sometimes you have to do it. Cardiac screening, very important to avoid a myocardial infarction, and you have to deal with mortality. In nearly 1% of the case, you will have 10% of deaths. And lower extremity ischemia concomitantly could be a risk factor. So do a global angio-CT scan going down to the distal segment. Conclusion, it's a revolutionary tactic. We are inside the revolution, but you need an excellent patient selection and an experienced team in a center of vascular surgery with all the tools for a good surveillance and deal with the new generation endograft. I thank you for your attention.